Hello and welcome to Health Matters on Channels Television. We are so glad you could join us. I am Mary Alale Yusuf. It's wise not to ignore a toothache because it could be something more sinister. Ludwig's angina is a skin infection that occurs on the floor of the mouth, underneath the tongue. It is named after a German physician, Wilhelm von Ludwig, who first described it in 1836. This bacterial infection often happens following a tooth abscess, which is a collection of pus in the center of a tooth. It can also occur after other mouth infections or injuries. According to the American Journal of Medicine, affected individuals are usually 20 to 60 years old with a male predominance. My guest is a consultant oral and maxillofacial surgeon with the Lagos State Health Service Commission, a fellow of the Chartered Institutes of Administrators, and member of the Institute of Directors. You're welcome to the show, Dr. Akim Alawudi.
Thank you so much, Mary. It's always my pleasure to be here.
It's been a while, yeah.
Thank you.
So, this infection at the floor of the mouth, what kind of symptoms does somebody come up with when it's there?
Okay, thank you very much. When you were giving the preamble, you said it's all about Ludwig's angina. It's an infection, so there are certain cardinal signs when we are talking about infection. The patient will have fever.
Okay.
That's the commonest thing. The patient can tell you that he's having chills and rigors. All these come with fever many of the times. Then the commonest sign is swelling. A swelling of the cheek that can get to the neck, that can even get to the chest, as bad as it is. So those are the signs. And when you were giving the preamble, you have mentioned some very important etiologies or the causes of this condition. Many of these patients will tell you that they have had a toothache.
Okay.
It could be as simple as a toothache. It could be as simple as a jaw fracture.
From
right?
a fall?
From a fall, from a blow to the cheek. Somebody will give a blow to someone on the cheek and the person will not really want to do anything about it. He'll go to the nearby chemist to buy antibiotics or analgesic. But at that time, something is developing. An abscess is developing inside the bone that will get to the potential faces of the face. So
okay, so the abscess doesn't actually have to start from the tooth. It can start from the jaw.
It can start from the jaw. It can start from under the mouth. It can start from salivary glands. The things that produce saliva for us in the mouth. If there's an abscess, if there's a infection of it, the abscess too can start from there. And there are potential faces all around the face. We call them potential spaces because they are not spaces like that, but they are potential in the sense that things can track in there. Pus can track into those spaces. So the spaces are submandibular space around here, sublingual, submental spaces all around our face. We have potential. Submental.
That sounds
under the chin.
like, okay, that's under the chin,
mental is
not
chin,
in the head.
Not in the head.
Okay.
Submental under the chin.
Okay.
Submandibular under the mandible. Mandible is the lower jawbone. Then you have sublingual.
Under the tongue?
Under the tongue. Then you have submasseteric. There are certain muscles on the cheek we call masseter muscle. You have potential spaces within these muscles where the pus can track into.
Now, in the absence of a toothache or a tooth abscess, does it have to be an injury? Does it spontaneously happen sometimes?
It cannot spontaneously. Wait, thank you for that question. It can be spontaneous in children.
In children. Okay.
In fact, in children, most of the time we say it's idiopathic. We cannot really put a cause to it, especially for young children, babies and co. If you have Ludwig's angina in such patients, it's usually idiopathic. We cannot really tell
why.
Yes,
why
because at that point,
up.
you're not seeing any curious tooth in the mouth. You're not seeing any locus of infection anywhere. So, but in the adult, there must be something that is bringing it up. It could be all these things I've mentioned and the one you also mentioned.
How common is it in Nigeria?
It's very common in Nigeria. Although if you look at the literature, they will tell you it's rare, but it's common in Nigeria because of factors that are making it common. And number one is poverty.
Okay.
Poverty is the first predisposing factor in Nigeria. People have issues around the mouth. They just sit down at home. They self-medicate. They don't go
so
to the hospital.
It's because they're not coming to the hospital, not because they're not eating well.
It's not. Yeah, that's one of the predisposing factors. Malnutrition.
Okay.
Malnutrition is one of the predisposing factors. When they don't eat well, it can tilt them to have such a condition. There are so many predisposing factors. One of them is diabetes mellitus. It's the commonest one that we see in this country, because when you have an uncontrolled diabetes, you know, when people that have uncontrolled diabetes can easily have infection.
Yes.
So something that can easily, that might not give Ludwig's angina in a patient that has a controlled diabetes, will have, such a patient can have Ludwig's angina if the diabetes is uncontrolled. And it's usually very bad when it's uncontrolled.
How much of an emergency is this condition? It is
a medical emergency. It's a serious one, and that is why, in fact, the name suggests the emergency state. Ludwig's angina. Ludwig is the name of the person that came up with that word in the 1890s. Then angina means suffocation.
Okay.
So such patients are suffocated when they have this condition. Yes, because
they cannot
breathe.
Take in air?
Yeah, they cannot take in anything in. If they want to swallow, it's difficult, dysphagia. If they want to, breathing is difficult at that point. So you see them, they are restless, they are anxious, they are agitated. So that is why it is an emergency. And we usually say, do not let the sun set over this condition, because in many cases,
the gospel of toothache.
Yeah, when the next day, when you see that patient, the patient is usually very bad compared to.
That's what I was about to ask you. Let's talk about maybe when the condition starts to when it becomes really dangerous. How long is that usually?
It's very rapid. It's an acute condition. It's very, very rapid. Maybe under 1 week.
Okay.
1 week. It's an acute situation that needs to be addressed.
But never a 24-hour situation.
It can be a 24-hour situation. It depends on when this patient presents.
Okay.
Patient has been at home. They have been managing on their own, self-medicating. They now come to the hospital at a point when the patient is not breathing well. This patient cannot swallow. Is already breathless. It's very, very terrible situation, so that can be addressed. And usually a multidisciplinary approach. The maxillofacial surgeon is just the main specialist in charge. Other specialists like the ENT surgeons,
definitely,
the anesthetists, they also have to be part of the management, because when Ludwig's angina is special because it's not just treating the infection of the mouth or the jaw or that.
You are now having a breathing problem.
The breathing issue is there. That has to be sorted out.
Probably you have respiratory infections along other infections.
Yes. Those are the complications. So that's why I said it is more disciplinary. So whenever the patient comes in and is breathless, you know that, yes, the ENT surgeons have to be involved, because there's something we call tracheostomy that has to be done to relieve the respiratory obstruction. Of course, maxillofacial surgeons too can do that, but ENT does it.
You're talking about a tracheotomy. Yes. That means you're making a hole in the patient.
Yes.
And you're passing air through that hole.
Exactly.
Where do you make the hole?
On the neck, around the neck.
So the passages, air passages can be so closed that the patient might die?
Exactly. So that's why you need to create an access for the airway. Because at that point in time, there's airway compromise. In most cases of Ludwig's, there's usually an airway compromise. But you see some patients, whenever they come in earlier than others. They do not have airway compromise at that point. But most cases of Ludwig's, there's airway compromise that has to be sorted out as soon as possible. They can't feed well too.
Ludwig's, obviously, usually it would be like coming from the tooth, right?
Yeah, in many cases.
You've spoken of cheek swelling and pain and all that. Can it come just like, it can come just like a regular toothache? Because I'm trying to find out, when somebody ought to know that this isn't something you can put off until later. Yes.
You're talking about the etiology. The toothache is the commonest cause. It can just start as a hole on the tooth that will now progress to pus forming around the tooth, goes into the bone, gets into the muscles around the face.
Minus pain.
In many cases.
Minus pain.
In many cases, there will be pain. In many cases, there will be pain.
I'm asking because
for you to lead to Ludwig's.
Some people have maybe a filling, okay, in the
Okay.
tooth, in one of the molars. And, due to usage or whatever, the filling pops out. So there's a hole in the tooth right now. But it's a quiet hole. There's no pain, there's no trouble. Is that a potential danger?
It's a potential danger. It's a potential danger because in many cases when there's a hole, like you said, this condition, lodges can actually start from there to progress down, then get into the bone, goes into the muscles and the connective tissues around. So that can now lead to Ludwig's angina. But we are not saying that everybody that has a hole on the tooth or everybody that has a blow given on the cheek will have Ludwig's angina. But whatever happens to a patient, such a patient must go to the hospital.
In which case, what is your definitive diagnostic test for it?
In many cases, when a patient has Ludwig's angina, we don't say we want to do a test. It's something that you can see.
Okay.
When you see the patient, you can actually diagnose that, yes. And of course, you ask very brief questions. It's not the time where you spend the whole time asking questions.
Perhaps by this time he's still breathing well. That's why I'm asking.
Yes, you just want you start the management immediately. You want to know the root cause of this problem. But the most important thing is to start the management. If there's no airway, whatever is causing the issue, tackle it. The issue. If it's an offensive tooth, that has to be getting rid of. If it's a fracture that has refused to heal, that is leading to this condition, we need to take care of that too, a way of managing the fracture. But like I said, once there's an airway issue, if the airway compromise is the biggest issue that has to be sorted out first, that's what will kill the patient fast.
Okay, assuming just anybody, how does a person prevent this or reduce his or her risk of getting Ludwig's angina?
Yes, regular checkup. The local dental check.
Is it 6 months? Every 6 months? Is that
okay?
okay?
Needs to get to see the dentist every 6 months. Then, or if the local dentist sees the issues around the tooth and is leading to Ludwig's, he can now refer to a consultant maxillofacial surgeon to manage issues of Ludwig's angina. Then, of course, whenever the patient goes to the hospital, there has to be a check of the face generally. So if something is developing, the doctor there will know that there's something coming up.
You've raised two issues for me here. First of all, you spoke about a local dentist. Let's talk about this local dentist. Are they equipped to know when somebody has such a problem?
They do. They are equipped to, they know.
So we are safe in the hands of our regular dentist.
Yes, you are safe.
Because on a normal day, when you go for a checkup, they don't take you to a maxillofacial surgeon. You just see a dentist.
Yes. Well, that's what I'm saying. When it gets to Ludwig's angina, the maxillofacial surgeon gets involved.
Okay. But the dentist can see
pick
it and recognize it.
The general dental practitioner can pick the issue, the condition, whenever the patient presents. But when it comes to the management of the condition, the specialist, the maxillofacial surgeon, has to be involved in the management because it's usually very, very, very fulminating, and it's not something we need to play with. Something we need to tackle on time.
Then you mentioned examination of the face.
Yes.
Is this going to take place in the dentist chair or in a regular physical exam?
The dentist too can check the face, can check, apart from checking the mouth, can just do a general examination. We call it extraoral examination, checking around the face. If there's any issue around the face.
Swelling?
Yes, swellings basically. Checking warmth.
Okay.
You know, if there's warmth, you are looking for signs of infection, basically.
How about if there's a situation where the progression is so rapid or they didn't recognize it in time and the person is at home? Is there something someone can do at home to relieve the pressure while going to the hospital?
I don't think there's anything anyone can do at home for such a condition. The patient has to get to the hospital on time, as soon as possible.
All right. We're going to take a short break. Please stay with us as we take this very short break and meet us on the other side. Welcome back. We're talking about Ludwig's angina, something that is quite common in Nigeria and shouldn't be if we are careful. The number to call is 0808-054-2233 if you have a question. That's 0808-054-2233. And you can also tweet at CTV_Mary A while we continue to find out about this disease. Now, these swellings that come on a person's face, must they always be invasively drained? Can't they resolve on their own?
No, they cannot resolve on their own. The drainage is one of the modes of treatment that we do. You have to drain because you have that, or you have to decompress. There's pus discharge. There's pus collection. You have to make sure the pus is drained.
What if
to relieve pressure?
It's not from inside all those submandibular and sub-whatever spaces, just a tooth abscess, and it has not progressed to obstruction of the airways.
Thank you. For you to call it Ludwig's angina, those spaces have to be involved. The submandibular spaces on both sides of the jaw have to be involved. The submental space has to be involved. You can't say it is Ludwig's angina if it's just restricted to its local origin.
Okay.
So Ludwig's angina must involve these spaces, submandibular spaces, sublingual spaces that can now spread maybe to the chest, it can spread to the throat, retropharyngeal area. So that is it. We have to, of course, we can't go retropharyngeally to drain, but you have to drain where you can see the submandibular, sublingual, and around the neck.
Let's take this call from Alpha in Lagos. Hello, Alpha.
Hello. Good afternoon.
Hello. Good afternoon, Alpha. What's your question?
Yes, I want to find out about when somebody have a boil in his gum and he's going down a pus. Is it a Ludwig's angina too?
Thank you very much, Alpha. You know about those little...
A boil on the gum is not Ludwig's angina. That's very localized. That is not.
And probably not as serious.
No, not as serious.
But that is so painful.
Yes, but not as serious. Ludwig's angina is something. It's on its own. It's something that it's defined by those things I've mentioned. Those spaces have to be involved.
Submandibular spaces.
Yes, swellings around those spaces, and in many cases you have pus collection. You might not have pus at the time the patient is reporting. That's what we call it cellulitis. You can now have pus, which is abscess.
And that pus must be removed.
You have to.
Or you're not
you must drain. Although some people say antibiotics alone will take it, but you must drain the pus. It's key in terms of.
But the antibiotics to take care of it are readily available.
The antibiotic therapy is one of the modes of treatment. Taking care of the source of infection is another mode of treatment. If the infection is coming from an offensive tooth, yes, the dentist will extract the tooth.
If it's a fracture?
If it's a fracture, handle, yes, you have to reduce the fracture and treat the fracture. So there are about 3 or 4 major, then you have supportive therapy. This patient has to be placed on fluids to drain the toxins from the system. This patient has to be, have bed rest.
Are you serious?
Fluids. Yes, IV fluids. Your
IV fluids and bed rest.
Yeah, the patient is going to be in the hospital for a minimum of 5 to 7 days. It's not something you come in and go.
Serious.
Yes, the patient will be admitted.
What's the prognosis like? What's the outlook? Do they make a full recovery?
It's very good, yes, when they come to the hospital on time. The prognosis is very high now. In the days when we didn't have good antibiotics, yes. If you check the literature, they will tell you those days the mortality rate was about 70 to 80%. Just to tell you that antibiotic therapy is key in management.
Okay.
But now that we have good antibiotics, and of course, if patient can be able to afford and access health care on time, these patients do well. They go home and walk out of the wards to their homes.
Some people go about making piercings in their tongues. They put earrings there.
Thank you. That's
How safe is this practice?
That is one of the things that can cause Ludwig's angina.
Let's quickly take Ifeanyi before we tackle this. Hello, Ifeanyi. Ifeanyi is in Bielsa. What's your question?
Yeah, Ifeanyi from Bielsa.
Go ahead with your question.
Good afternoon.
Yeah.
Hello.
Hello, Ifeanyi. We can hear you. Go ahead.
Okay, I just want to know what is the cause of this mouth odor? Is it from the stomach? Okay, I said what is the cause?
That is a totally different topic, but because we have a maxillofacial surgeon who is also a dentist, he can quickly tackle that.
The mouth odor thing has a lot of causes, local and systemic.
Of course, this could be one of the reasons.
Yes,
because
definitely.
it's an infection.
Yes, there will be when you have Ludwig's angina, there's halitosis. Halitosis is
The
mouth
odor we're talking about.
So when you talk about mouth odor, there are a lot of things that can cause it. It can be as simple as a wound in the mouth or a hole on the tooth.
Can it come from the stomach, though,
Definitely,
like you
yes.
asked?
That's one of the systemic causes of mouth odor.
All right. So we were talking about the tongue piercings. Let's move back to our
Yes,
topic.
talking about tongue piercings, it is one of the causes of Ludwig's angina when it becomes infected. People pierce their tongue with unsterilized equipment. So when it gets infected, Ludwig's angina can actually arise from it. It's one of the causes of it, but it's not that common.
But let's
cause
say they
of-
use a very sterilized equipment, okay?
Yes.
Can't it become infected after? Because you keep putting an earring in there. Sorry, tongue ring.
Yeah, a tongue ring. Yeah, it can become infected. But you see, the other time I was talking about predisposing factors, there has to be predisposing factors for many of these things to happen, especially Ludwig's angina.
Okay.
Like I mentioned, uncontrolled diabetes, uncontrolled AIDS,
Okay.
malnutrition, all these things have to be involved, or some of them have to be
But
involved.
generally, you're okay with the tongue piercing as long as the person
if
does
you
it.
say I'm okay, fine. As long as, as long as it is done under sterile conditions, and this patient does not come down with infection of that tongue or the floor of the mouth. If the patient does not come down with infection of the tongue or the floor of the mouth, a Ludwig's angina cannot result from there.
So let's talk about swelling of the chest. In what cases does it go down so far? Isn't it extremely dangerous by this time?
Yeah, at the time.
Does it involve any of the heart's, structures?
Yeah, at the time it gets to the chest, it has become very serious. It's something that has to have been attended to very early. And like I said, it has to do with when this patient presents. If they come in very early, it's not going to get to the chest on time. But by the time it's getting to the chest, it has become extremely serious that has to be tackled.
There's one question I really must ask you before we leave. What if a baby gets this problem? How is a mother to know her baby's life could be in danger?
Most of the babies that have had it had swellings. They had swellings.
You've had babies with this condition?
Yeah. Yes. Yes. And that's why I said at that age, usually idiopathic is unknown. As in the cause is unknown.
Okay. So he has a heart swelling.
No, not heart swelling. I thought you meant Ludwig's angina.
No.
I've not seen a baby with heart.
If a baby has Ludwig's angina,
okay,
how does his mother know?
That's why I said the mother will see a swelling of the jaw around here.
It's still going to be on the jaw.
It's classical. That jaw swelling will be there, around this region. Yes, the few babies that are treated and operated upon had swellings around the submandibular region.
But they can get to the hospital in time to have it
Yes, in many cases, when they get to the hospital, I can't remember losing a patient, a baby to...
That's good news. It's very good news.
It's very good. The treatment, the prognosis is very good. Once they are treated, they are fine.
Okay, so
Drainage
thank you so much. I'll have to stop you there, Dr. Alawode. That was really, really interesting. And thank you for taking this topic. If we come often enough, people come often enough, it should fall.
Yeah,
the rate
definitely.
should fall. Thank you so much.
Thank you
for being with us on the show. Enjoy the rest of your day. I am Mary Alale Yusuf.